Hopefully you love the classes and you will be more interactive. So today's class I will be covering with the upper limb and lower limb. See, extremities are too many. We have total 6 things to cover. Okay, if I just bring up the index, we have the head and neck. Okay, we have the head and neck neuroanatomy, then general anatomy a little bit, and then upper limb, lower limb. Okay, upper limb, lower limb, thorax, abdomen and pelvis, histology, general embryology, systemic embryology and genetics. Okay, so it will be a rapid revision. Good, thank you so much. Yes, thank you so much. Actually I am not able to see what you are able to see simultaneously, so this I am also getting used to it, don't worry. Just bear with me for this first class, and in case if you have Android phone, I would recommend all of you to download the application insideourbody.com. You can download the mobile application in Android phone and you will get a better user experience in a mobile phone Android application. Okay, otherwise you can use the website link, there is no problem. Okay, all right. So we will try to discuss the upper limb and lower limb, the major important topics, in 2 hours. So as you know, it's fairly not possible to cover the entire thing, but yes, we will be trying to cover the MCQs wise discussion so that it goes well. Okay, so please tell me the correct answer to this question. A 32-year-old man is unable to extend his wrist after sleeping with his arm compressed over a chair. So what condition we are talking about? Yes, I need the answers in the chat box. I have not done your class as I have joined late. So is there, yeah, see, just try to follow through right now the question which I am asking. Okay, don't worry. So 32-year-old man, yeah, correct answer is Saturday night palsy. That is correct. So what option would be the correct answer in this? B. People are going for radial groove. Yes, excellent. So they are giving you some hints in this question. That is, one head of triceps is still functioning, lateral 3.5 finger sensation lost over the posterior arm, and the lateral 3.5 fingers. Okay, so the correct answer to this question would be, that is answer number B, that is radial groove. So let us quickly see the radial nerve. Okay, so it will be helpful to you in your exams. See, radial nerve, ulnar nerve, see this, have a look at this topics of upper limb. So in this topics, the axillary artery, its various branches, brachial artery, okay, and axilla, brachial plexus, all these are certain important topics. So I have listed down 13 important topics for upper limb. Okay, so the correct answer which was related to the radial nerve. So let us jump to this radial nerve to discuss and understand. So if you remember the radial nerve course, the beginning and the branches, we have already discussed. It's a branch coming from the posterior cord of the brachial plexus. Okay, and we also know it passes through the lower triangular space. You remember these triangular spaces, the quadrangular space and the upper triangular, the lower triangular space in the radial groove. Okay, so it runs in the spiral groove. I'm spending less time per topic just to have a recap. It's a rapid revision. Okay, if you want detailed things, I have taken some classes on YouTube also. The lateral intramuscular septum and lies deep to the coracobrachialis and ECRL is extensor carpi radialis longus. Okay, axilla, it gives off the branch, then it spiral groove, it gives the branch, and then finally we have some terminal branches. Okay, so those are superficial and deep branch. So let me show you this photograph to have a good understanding about this. Now please pay attention. You know, radial nerve is coming from this posterior cord. Please refresh, guys. If the video has been stuck on your end, please refresh. So now you see radial nerve, we know from where it is starting. See, for all the 3 nerves, radial nerve, median nerve, ulnar nerve, we have to see from where it's starting. Okay, and then what all branches it's giving. So you all know this radial nerve is supplied coming from the posterior cord, and we know in the arm region, in the back side, we have, yes, it's from the workbook. If we know that it is the radial nerve which is supplying the main muscle in the back of the arm, which is that muscle triceps. Now, as you know, triceps has 3 heads. Okay, so there is a long head, lateral head, and a medial head. Okay, so now please pay attention. The long head of triceps brachii is getting the supply from the radial nerve from the axilla region only, whereas there is another branch which is coming from the axilla region only, to the medial head. So medial head is getting the supply from the radial nerve by a branch in the axilla and by a branch in the radial groove. So it's two places where it's getting innervated. But if we talk about the lateral head, it is getting the supply only in the radial groove region. So the question was regarding the radial groove region. So we know one head which is spared, so that answer would be the long head. So long head is being spared. Okay, that is the question. Medial head. Okay, so we know the concept of the triceps. Okay, sorry for the technical glitch if someone faced, I'm so sorry, but you have to bear with the internet connections, everywhere is different. So next, then we have some posterior cutaneous branches. Okay, there is no problem in that, but please pay attention to the triceps, okay, which is very important muscle for the action of extension. Okay, so now see other muscles. It is supplying the brachialis, brachioradialis, ECRL, okay, same muscle which we just discussed, and its terminal branches, it's giving the superficial branch and a deep branch. Now please pay attention again. Deep branch of radial nerve is the nerve which is known as posterior interosseous nerve. Posterior interosseous nerve is again asked in the MCQs that it is a branch coming from which nerve. Okay, so it's a deep branch of radial nerve. Another question, that there is a superficial branch of radial nerve. Now you see it is in the forearm, but where the bifurcation is happening, I am covering many questions in one go. Okay, so in the place where you can see in the lateral part of arm, it's mentioned forearm, so we are talking about the cubital fossa. So within the cubital fossa, you remember the contents of cubital fossa, that was MBBS mnemonic, right? MBBS from medial to lateral, or the mnemonic was MBBR. Okay, so R was the radial nerve or S was the superficial branch of the radial nerve. So this is the superficial branch of radial nerve which we were talking about. Okay, and if we talk about the injuries of radial nerve, which is very important again, so injury of the radial nerve is related to these few things. So injury in the axilla, number one. Okay, if I just highlight injury in the axilla or crutch palsy. Okay, then we have injury in the radial groove, that is Saturday night palsy as per the MCQ, and then injury at the elbow. Okay, so please pay attention for a minute. Injury in the axilla, so crutch palsy, this is the radial nerve injury due to the pressure by the upper end of the crutch. Okay, so that is why it is known as crutch paralysis. Okay, so what happens, there is a loss of extension of forearm, weakness of supination, and triceps is involved also. So there will be ultimately what will happen, there will be flexed elbow, opposite. Okay, then what else, there will be wrist, loss of extension of wrist and fingers, so there will be finger drop and wrist drop. So all these features will be given to in the question, you have to select accordingly. Then we have results in loss of sensation in the lower and lateral posterior aspect of the arm, posterior aspect of the forearm, hand, and lateral 3.5 fingers. So this is due to the superficial branch, because we are talking about the loss of sensations. So you should know the superficial branch of radial nerve. So this is about the crutch paralysis, specific question. Then if we talk about the Saturday night palsy, which is the classical MCQ which is asked. So in this, all the above signs and symptoms except the medial and long head of triceps which are preserved. And now you know the radial groove we have discussed, and the question can come for the Saturday night palsy in different formats, like mid shaft fracture of humerus. Okay, wrong IM injection can be given, although it's related more to the axillary nerve. Okay, that is related to the deltoid. Then injury at the elbow, which is related to the lateral epicondyle fracture. So this can be a orthopedics integrated MCQ clinical case scenario. Then we talk about the entrapment of neuropathy of the deep branch of radial nerve. Okay, so that is the injury at the elbow. Then we have the sensory loss and finger drop, which is present in the third case scenario. Okay, and you can classically see there is an MCQ which has been asked previously regarding this, the arcade of Rose. So this is something a very fancy name. This is for the fibroeponeurotic proximal edge of what thing? Supinator muscle. That is the important part, supinator muscle. So it is caused by the compression of these sharp margin of the supinator muscle. So wherever you hear the question arcade of Rose, so you can make out that there is talking about the injury at the elbow. Okay, then clinical features will be same, loss of extension of wrist and fingers, but there will not be any wrist drop in this specific case scenario. Why so? Because here the ECRL has been spared. Okay, because injury is at the elbow. Then pain and tenderness over the extensor aspect of the forearm will be there. Okay, so ECRL is an important wrist extensor. So weakness will definitely be there, but it will not be a complete wrist drop. Okay, so this is the image showing the same, the crutch paralysis and the Saturday night palsy. Direct pressure on the radial nerve by the drunkard who fall asleep on his one arm over the back of chair in this manner. Okay, so this is the Saturday night palsy, and the features we have already discussed. Then we also have a posterior interosseous nerve, okay, which I discussed regarding the deep branch of radial nerve. So there is something regarding this posterior interosseous nerve which you have to remember, that if there is an injury to the posterior interosseous nerve due to the radial head injury or surgical excision of the radial head or supinator syndrome, any kind of language can be given. So there will be a very important entity, that is the triceps. The triceps is spared. Okay, you know already why it is spared, it is supplied above. So triceps will be spared, there will be no problem in elbow extension. Okay, I hope it is very much easy to understand. There will be no wrist drop also. Why so? Because ECRL will be spared. Okay, ECRL, which was already supplied above, it will be spared. Then what about the finger drop? Finger drop will be definitely present, because there will be loss to the extensor digitorum which is involved. Okay, extensor digitorum which is involved, and superficial branch is spared. That is important. Okay, so there is no sensory loss. So we are talking about only the PIN, that is the posterior interosseous nerve injury. We're not talking about the superficial nerve. So there will be no sensory loss. Okay, so okay, then we come on to the next question. So this we have discussed. Next, let us try to solve this question. Please give an answer. What would be the answer to this question? Try to attempt. Try to attempt this question. Yes. What is the answer? Okay. The 40-year-old woman shows difficulty holding the paper between the fingers. So it has been given, that is the Igawa's test is positive. Okay, Igawa's test is positive, and she cannot adduct her fingers. This is the main hint which has been given to you. So you remember pad and dab. Okay, so can you use this mnemonic and try to fetch the answer? Yes, anyone? Many people are confused between A, B and C. Okay, so the correct answer to this question would be, they are asking the muscle group. Yes, is it lumbricals, dorsal interossea, palmar interossea, or the thenar muscles as a whole? Yes, the correct answer is answer number C. Someone answered regarding the C. So it is the palmar interossea. Okay, so let us come to this interossea thing to understand this better. Okay, interossea. Okay, we come on to this topic, muscles of hand. Okay, so muscles of hand we have already discussed previously, if you remember. Okay, muscles of hand. Yeah, most of the people are now answering C, that is correct. So muscles of hand. Now, yeah, I will come to the card test, don't worry. Okay, so you remember the muscles of hand, 20 intrinsic muscles of hand, right? And out of these 20, we should know the names. So thenar muscles, and these are actually the thenar muscles which I am highlighting now. These are the 4 thenar muscles: abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and adductor of the thumb, that is the adductor pollicis. So these 4 are the thenar muscles. If the question is the muscles of thenar eminence, so only top 3. The thenar eminence does not have adductor pollicis. Again a question, I am covering many questions in one go. Okay, so another question, all these 3 muscles, the thenar muscles specifically, they are supplied by median nerve, whereas adductor pollicis is being supplied by ulnar nerve. Very important. Then hypothenar muscles. So you remember the thenar group, this is the thenar group. Okay, towards the thumb side, you can remember thumb, thenar. So this is the thenar, and this is the hypothenar group. Now in the hypothenar, the first muscle which you encounter is the palmaris brevis. Okay, I actually have limited time, so I am not rotating every muscle in 3D right now. If you want those discussions, you can see the full-fledged classes. Right now I am just focusing on the MCQ and the main core concepts of each extremity, so that at least you have something in your mind before the exam. So palmaris brevis, which is a subcutaneous muscle in this region, in the hypothenar region, and you know the other name muscle palmaris longus, which has a long tendon in the front. Palmaris longus is the muscle of the superficial compartment of the forearm, if you remember, right? So here we have the palmaris brevis. Then we have abductor, digiti minimi, flexor and opponens. So digiti minimi is the 5th digit. So abductor, most lateral one, then flexor, and between these two deep to it, opponens. Similarly here we have abductor pollicis, then we have the one which is there, that is the flexor pollicis brevis. If we see below these two muscles, there will be opponens pollicis, and even if you remove all these, you will see in this region there will be the adductor, there will be the adductor pollicis. Okay, adductor pollicis with its transverse heads and a oblique head. Okay, so very important point to remember, median nerve is participating to supply the thenar muscles. Okay, whereas ulnar nerve is supplying the adductor pollicis. Then we have the palmaris brevis, which is being supplied by the superficial branch of the ulnar nerve. Okay, you cannot hear anything, please restart the class, rejoin the class. I hope many people are not having the same issue. Audio video is fine. I really hope you are not having this technical glitches, because some things are actually out of my control also, but most of the people are able to connect and see. Okay, all right. So if someone is having some problem, there is some internet issue. Okay, okay. Superficial branch, it is branch. Okay, it is superficial branch of ulnar nerve, then deep branch of ulnar nerve. Okay, so you can see there is this supply, that is the thenar muscles, which is being supplied by median nerve. Okay, then we have adductor pollicis supplied by ulnar nerve. A very important question I am going to tell you right now. Then you have the ulnar nerve deep branch and superficial branch, which is supplying the hypothenar. So can you see the ulnar nerve and median nerve, and also there is radial nerve. Radial nerve is supplying the extensors or long extensors of the forearm. So if we move the thumb by the simple movements of the thumb, I show you this image, by simple movements of the thumb, you can appreciate all these nerve injuries. So the only digit out of the 5 which you can ask the patient to move in different motions. So you can see the muscles which you are going to test. Ulnar nerve is supplying the adductor pollicis. Okay, so adduction of the thumb you can check to check the ulnar nerve. Then you can do flexion of the thumb to check the median nerve. Then you can also do extension of the thumb to check the radial nerve. So that means by doing these 3 movements, flexion, extension and adduction, you can check all the 3 nerve injuries. Okay, next, so you can see these images. Okay, same things which we have discussed, and now we come on to the tests. So you can see there is another test, that is pen or pencil test for abductor pollicis brevis. So this is the resting or paralytic position which is shown in the red dotted lines. Okay, so the patient is asked to touch this pencil. Okay, and if the muscle is working perfectly fine, then this action should happen, otherwise he will not be able to do, and the position will be this. Okay, so that is for adductor pollicis. Then abductor pollicis. So this is the adductor. Now you see another sign that is also asked in the exams, that is Froment's sign. Froment's sign is related to this. You can see paralysis. Let me highlight this. It is injury to the ulnar nerve deep branch, and we are talking about the paralysis of the adductor pollicis. Okay, so that is the Froment's sign for. So please remember this Froment's sign. Froment's sign, what is happening? The patient is asked to grasp the object between the thumb and other fingers. What is happening? There is extension. There is extension at the interphalangeal joint. This one. Okay. But if the patient's adductor pollicis is being paralyzed, so what is happening? the action of the flexor pollicis longus is happening and there is flexion of the interphalangeal joint. Okay, so the patient will be able to hold the the structure with the help of in this manner. So there will be a slight motion. Okay, so some people are not having this problem. Okay, by using, see, I hope so. Most of the people, I can see 135 people are not having any problem. They are able to join comfortably and they are able to see. Only 1 or 2 students are not able to join. So whatever platform if you use, be it any Google Meet or anything, so internet issue is there from 1 or 2 students side. So what can I do in that? Please be respectful in the chat. Okay, and I hope everyone is able to attend the class comfortably. There is no problem. I really hope so. Is everything is fine? Okay, most of the people are able to attend comfortably. Only 1 or 2 students are not able to have the video lagging or some issues. So please refresh or see your internet connection. Okay, don't disrupt the class unnecessarily. That is the main problem, keeping it open to public, general public to join. Some people can have problem also. So anyways, so in paralysis to the adductor pollicis. Okay, so that is the muscle which is involved in this case. So nerve which is involved is injury to the ulnar nerve, that is the deep branch. Okay, so that is a Froment sign. So in the Froment sign, what is happening? There is slight flexion at this interphalangeal joint, and that is happening due to the working of FPL. Okay, FPL, as you know, flexor pollicis longus, that is the flexor in the flexor compartment, deep compartment of the flexor region. Okay, so in the forearm you have superficial compartment and deep compartment in the flexor region. In that deep flexor compartment muscle is the FPL. Okay, then we have palmaris brevis, we have discussed. Okay, then we come on to the question which was related, that is lumbricals and introitiae. Okay, so lumbricals, so just have a look at lumbricals. Lumbricals are the muscles again. Okay, so lumbricals are, the action of the lumbrical is in this manner. You can remember lumbricals start with letter L, so make this L and to remember the action very easily. Action is, so what is this normal action? It is flexion. It is flexion at the metacarpophalangeal joint and extension at the proximal and distal interphalangeal joint. So that is the action of the lumbricals, that is normal action. Okay, anterior introitiae, so what you are asking, FPL is supplied by the flexi. If it's a deep muscle of the flexor compartment, so it will be supplied by median nerve, and that is the anterior introitious nerve. Okay, so we are not discussing that everything. If I keep on talking, it will not end. Okay, the upper limb cannot be possibly covered in 1 hour, you also know that, but I am trying my level best to summarize and touch on the main topics. So see, so lumbricals, we know the action, we have, I told you the action. Okay, so if there will be paralysis to the lumbricals, the nerve, the paralysis that is happening, so there are 4 lumbricals, first and second are supplied by median nerve, third and fourth are supplied by deep branch of ulnar nerve. So suppose if there is any injury to median nerve or deep branch of ulnar nerve and lumbricals are not working, so what will happen? There will be the opposite action, that is, so in this L there is flexion, so do not do flexion, we will do extension. So extension at the metacarpophalangeal joint, then there should have been flexion at the interphalangeal joints, so there will be extension at the interphalangeal joints. Sorry, I'm so sorry, extension at the interphalangeal joint should have happened, but there will be flexion. So there will be flexion of the interphalangeal joint and extension of this metacarpophalangeal joint, so exact opposite basically. So what will happen? There will be the clawing of hand. Okay, so depends upon which nerve is damaged, so you can see the digits involved. Another question which is asked is that origin. So muscle is attached to the tendon of the FDP. So have a look at this image on the left side. You can see the tendons of the flexor digitorum profundus. Here you can see the FDS, that arrangement of FDS, if you remember, okay, in this manner. So FDS arrangement is also there. Okay, so that means that FDS splits to attach laterally, you can see here, to the middle phalanx, whereas FDP, which is below, deeper tendon which is attaching to the distal phalanx. Okay, So that means we are talking about the FDP right now. So you can see this tendon of FDP which is giving this attachment to this muscle. So this is the muscle that is the lumbricals, okay, which we just discussed. So there will be 4 lumbricals, first and second unipinnate, third and fourth will be bipinnate. Then we talk about the interossei. So you can see the interossei will be 4 each, 4 palmar and 4 dorsal. The name is interossei, that means between the bones, okay. So between the which bones? Between the metacarpals, okay. So you can see again they are numbered from 1 to 4 from lateral to medial, but palmar interossei, unipinnate and dorsal are bipinnate. That is the important point to remember, okay. And you see the innervation. The innervation is by the deep branch of ulnar nerve, again for both of them, be it palmar interossei or dorsal interossei. So that means interossei are being supplied by ulnar nerve, simple. So you remember the mnemonic, that is the reason the MCQ was also attached. So we have ADD, okay, ADD, that is PAD, that is palmar interossei is helping in adduction, whereas dorsal interossei is helping in abduction, okay. So that is the difference between ADD and ABD, okay. So now you know the actions of palmar and dorsal interossei, you know the supply of palmar and dorsal interossei, okay. You can see these interossei here, okay. So these are the palmar and dorsal interossei, these are the palmar interossei you can see here in this region, and if you go deeper, so you can see the dorsal interossei, okay, similar manner. All right, then we come on to the next question. We have done this one, that is the answer is C, that is the palmar interossei. Then question number 3, try to answer this question. Yes, please try to answer this question. See, I can just share the PPT of the questions, okay. The whole of the class notes are already being printed to some people, and some people you know, I cannot just share all the notes just like that, okay. You have to attend the classes, you can see those notes in the classes in detail, but PPT for the MCQs I will definitely float, there is no problem in that, okay. So if you want to note down something while I am discussing, that's the actually utility of these classes. If everything will be given to you at the end, then you won't be attending comfortably, that is very important. There should be some kick actually, okay. So the correct answer, let us find the correct answer to this question. They are asking, the patient has loss of thumb opposition, okay, positive ape thumb deformity, very important. Ape thumb should itself give you a click of mind, what is ape thumb for, in which nerve it is involved, okay. Then inability to flex the terminal phalanx of the thumb, again a very important pointer. Then sensation over the lateral 3.5 is reduced. So it has been given, many hints are given to you for which nerve, median nerve, ulnar nerve or radial nerve. First clear that confusion, only then you will be able to answer. Yes, the correct answer is for the median nerve, okay. So they are asking about the median nerve at the elbow. Why at the elbow? Because you can see there is inability to flex the terminal phalanx of the thumb. So that is very important. Let me show you this median nerve now. Let us go to this median nerve. Okay. Just hold on. Okay. So we talked about the median nerve now. So please pay attention, median nerve is very important again, okay. So median nerve is formed by the contribution of the lateral cord and the medial cord, we already know that, right. So that has been already covered. Now pay attention to these areas also, axilla, arm and all. Very important MCQ, median nerve does not give any branch in the arm region, very important, okay. Then another important MCQ covered here in this photo, very important one. Median nerve gives the branch anteriorly, that is the anterior interosseous nerve. Okay, posterior interosseous nerve was the branch coming from the deep branch of radial nerve, if you remember, just now discussed. Contrast, anterior interosseous nerve is coming from the median nerve, excellently important. Then you remember the cubital fossa, the boundaries of the cubital fossa, the brachioradialis, pronator teres. The branch to the pronator teres is given again, you know, it is supplied by the median nerve only. but this branch to the pronator teres is given much before the cubital fossa. It enters the cubital fossa. So that means if there is any injury to the median nerve at the cubital fossa or below that, then pronator teres can be spared. Again, important MCQ. What else will be important here? You can see FDS, the flexor digitorum superficialis, the big muscle that is being supplied by this nerve. Another very important MCQ that is related to this, the flexor digitorum profundus lateral half. Okay, so lateral half of this FDP is being supplied by this median nerve. What is the nerve supply for the medial half of the FDP? Please write in the chat box if you know the answer. Okay, what is the answer to that question if you are listening very carefully? Yes. Is my audio video everything is fine? Yeah, correct answer, ulnar nerve. Excellent. So that means the medial half of FDP is being supplied by the ulnar nerve. The lateral half is being supplied by the median nerve. What else? The FPL, that is the question which someone asked in the chat box. So sir, FPL is being supplied by which nerve? Again, median nerve. Okay. Pronator quadratus, the deepest muscle of the flexor compartment, again supplied by the median nerve, specifically the anterior trochleus nerve, and this was the exact same question which was asked in the INI-CET exam recently. Okay. Then if we talk about the palmar branch, so you can see this palmar branch is also very interesting. There is a palmar cutaneous branch which is given by the median nerve, which is running over the flexor retinaculum. Okay, so there is a flexor retinaculum, you remember. Then if you see below median nerve, you know, it runs in the carpal tunnels, if you remember. Okay, so it runs in the palm and it supplies all these muscles. So you know all these supply already. We have discussed this in the muscles of hand. Okay, first and second umbilicals. So now you see the injuries, because that was the question which was related to our topic. Have a look at this clinical integration. So if we talk about the injuries to the median nerve, there is a very important injury, that is injury at the elbow. Okay, now injury at the elbow is, by the question can be coming in the form of supracondylar fracture of humerus. So you remember the humerus, okay, humerus bone, surgical neck of humerus related to axillary nerve, the radial groove related to the radial nerve, that is mid shaft fracture of humerus. Okay, then if you saw about the supracondylar fracture of the humerus, that is related to the median nerve. There is medial epicondyle, so nerve below the medial epicondyle, that is the ulnar nerve. So if there is an injury to the medial epicondyle, ulnar nerve. Then if there is lateral epicondyle, so the nerve running above the lateral epicondyle of the humerus, that is the radial nerve. So very important injuries, nerve injuries related to the humerus. So please pay attention whenever you get this hint of humerus. The correct answer is in your eyes, in front of your eyes. Then there can also be pronator teres syndrome, whereas there the nerve can be getting entrapped between the two heads of pronator teres where it is entering. Okay, so you can see the clinical features, various clinical features of this injury of the median nerve, that is paralysis of pronator teres, pronator quadratus, loss of pronation, as you can imagine. Then paralysis of all the flexors of the wrist except FCU and medial half of FDP. I hope you know why it is written there, right? Because it is supplied by another nerve. So there will be weakness of the flexion of wrist. There will be flexion but weakness if there is isolated median nerve injury. Then flexor carpi radialis, adducted wrist due to unopposed action of the FCU. Okay. Then FDS and lateral half of FDP, there will be paralysis, so there will be loss of flexion at the interphalangeal joints of index and middle finger, as we have just now discussed. So the classical question gives you the pointing index finger. So this is the key word which is given to you in front of you. Then you see this is the question which was asked actually in the MCQ. We had this words which were given, if you recall. The paralysis of the loss of flexion of the terminal phalanx of the thumb, very important. So that was the exact hint which was given to us in the MCQ, okay, which was just recently asked. Then ape-like thumb deformity, again asked in the MCQs very frequently, okay, that is itself giving you the hint of paralysis of the thin arm muscles. Okay, then loss of sensations over the lateral 3.5 fingers including their nail beds, so that is also a hint. So lateral 3.5, you know, the supply is by median nerve only. Then okay, then paralysis of first and second lumbricals, lag of index and middle finger while making the fist, that is also important. Okay, so this is the about something about the median nerve. And then you have the classical carpal tunnel syndrome, which you already know, ape-like thumb deformity, then sensory loss, these tests. Okay, then there is also something known as Fallon's test, which you know, that if the hold the wrist in forced flexion for 30 to 60 seconds, there will be median nerve compression. In case if there is median nerve compression, so there will be tingling and numbness sensations. Okay, so that is another question. Next, try to answer this question. We have to move a little bit fast. We have already lost a lot of time in the initial phase. Please try to answer this question. What would be the answer? Yes, any idea? Okay, so the patient is having some problems. That is, number one, you have to read 3-year-old child. Okay, elbow pain after being, this is the classical history, being suddenly lifted by the forearm in pronation. This is the main thing. So what they are asking, this is the case of pulled elbow. Okay, pulled elbow, if you remember, pulled elbow is related to what? So the correct answer becomes, that is answer number C. Okay, so this is, yeah, one person answered it correctly. Answer is C, nursemaid's elbow. So these kind of MCQs are very commonly asked. You tend to answer tennis elbow or olecranon bursitis, which you have heard more frequently, but the answer is nursemaids. Many people have answered correctly. Answer is C, that is correct. So let us have a look at this entity regarding the same. So we need to jump to this topic of elbow. Elbow joint. Okay, so in this elbow joint, I'm not going to brief about everything. We have already discussed that in detail. So I'm coming on to the clinicals. So you know this, we have already discussed exactly same in the classes. So student's elbow. Student's elbow is olecranon bursitis, which is classical, given in your MCQs. You know these MCQ very clearly. Okay, it's given in almost all the textbooks. So it is actually what happening, subcutaneous olecranon bursa, which is more important clinically. Okay, it is occurring in the students due to the repeated minor injuries on the elbow while learning on a hard surface. So if you are bored, you are sitting like this, there is an injury. Okay, so that is the olecranon bursa. So subcutaneous olecranon bursitis, that is student's elbow. So do not confuse with this. Compare this with another condition, that is the tennis elbow. Now classically, please remember, tennis elbow is related to the lateral epicondylitis. Okay, not the medial one. Medial one is different. So it is in the tennis players where the repetitive pronation of the forearm is happening. So lateral epicondyle, which you already know, is the common extensor origin, and if you know about the medial epicondyle, that is the common flexor origin. So that is the main difference. Okay, so you can see the lateral epicondylitis, torn common extensor origin. So there will be tenderness at the same point. Then you compare this with the golfer's elbow. So that is, golfers is for the medial epicondylitis. So again, there is repetitive use of the superficial flexor muscles. So same, see the action which is happening. Okay, yes. So tenderness over the medial epicondyle. Okay, so that is the main difference between the two. So you can see here the difference in the photos. If I just show you, just see them in contrast. Here you can see the extensor muscles are being shown. Here you can see the flexor muscles are being shown. Okay, so that is the gross difference. You can make out this is the radius. Okay, so brachioradialis would be somewhere here. So you can see this is the pronator teres, this margin, pronator teres, boundary for the cubital fossa, and you can see the common flexor origin. So these are certain, you know, hints in the images which you can get in the MCQs also. Then last you can see distended elbow, elbow fusion, that we can leave. Now you see this yellow colored line, this is very important. That was the MCQ which was asked, that is why I have added that to my notes already. So nursemaid's elbow, or also known as pulled elbow, it comes in different names, okay. So that is subluxation of the head of radius. It occurs in preschool children 1 to 3 years old, when the forearm is suddenly pulled in pronation, that is very important, okay. And the head of radius comes out of the annular ligament. You know, the head of radius is having a annular ligament around it, so it can just be coming out of it, so that is pulled elbow basically. So elbow is kept slightly flexed and pronated. So what happens, an attempt to supinate the forearm, it causes severe pain. So that was the exact thing which was given to us in the question, okay. Next we come on to this question, have a look, try to answer this question. I think this we have already discussed. By seeing one keyword, let me highlight that, I think you can make out the answer. Maybe you are able to answer. Try to answer it. What is the correct answer? Yes, answer would be, the question is regarding again arcade of Rose, okay. There is again hint given to you, and there is a tenderness over the extensor aspect of the forearm. So they are giving you very good hints. Yes, the correct answer is D, that is a superficial the deep branch of radial nerve, okay. So firstly you should know it's regarding the radial nerve, which we have already discussed, arcade of Rose, okay. So this is regarding the deep branch of radial nerve, okay. All right, so there is no finger drop, okay. There is no finger drop. Next question, have a look at this question. This is again very easy question. Try to go through this question. A 28-year-old athlete presents with severe inability to following the trauma, reveals the tarot in which, what happened? What, just being gone? Is it fine or not? Is it fine now? No, please refresh once. Today please manage with me. Next class I will take on YouTube. I am thinking that way. I will take on YouTube, something like that. Everything is fine. Some people are saying yes now. There may be some server issue from the backend. Please give a thumbs up. Everything is fine now. Audio, video. Okay. Please answer the correct question. The correct option. What is the correct option? The answer is A. Okay, no. Just C. Try to answer this. Try to answer this question. They are asking about the antero-inferior dislocation of the shoulder. The correct answer is the axillary nerve. Okay, I already told you that was related to the which part of the humerus, that was related to the surgical neck of humerus. Okay, so let me show you this diagram. You can have a look. Okay, it's regarding the shoulder joint image. If you see this nerve, can you see this photograph? Very clearly visible. Okay, so anterior dislocation, antero-inferior dislocation of shoulder, which is most common, and there is compression of the the axillary nerve. Okay, so they are indirectly asking you the same question, that is when the injury happens at the surgical neck of the surgical neck of humerus, when the injury happens at the surgical neck of humerus, there is injury to the axillary nerve. This is the radial nerve. Try to accept. Anyone? Please rejoin if you are facing any issue. Okay, the correct answer is adductor pollicis. Yes, that is the correct answer. We have already discussed this question. Adductor pollicis is the not the muscle for the thenar eminence. Okay, all right. Then yes, come to this question. This is very easy questions, direct one-liners. Ulnar nerve is also known as, yes, ulnar nerve. C is not the answer. Writer's nerve is not the answer. Please try to answer this question. Ulnar nerve is also known as, okay, you have not read the properly. Ulnar nerve is also known as musician's nerve, which is the nerve for laborer's nerve or the eye of the hand. Which is the name for these nerves? Can anyone tell me? Let me highlight this one. The laborer nerve or eye of the hand, which is this nerve? What is the answer to this laborer nerve or eye of the hand? Who will tell me the answer? Which nerve? Ulnar nerve is musician's nerve, and laborer nerve or eye of the hand. Yes, the correct answer, very good. That is median nerve. Correct. Median nerve. Okay. Median nerve is the correct answer. Yes, there will be a 3 to 4 seconds lag definitely in what I am saying and what you are seeing. Always in any live classes there is a 3 to 4 seconds lag. Okay, so don't worry on that. So the correct answer is ulnar nerve, musician nerve in this case, but I have told you an extra point that laborer's nerve or eye of the hand is also for the median nerve. Then axillary sheath is derived from which fascia? Yes, axillary nerve is derived from which fascia? Anyone? No, it is not clavipectoral. Please pay attention and tell me the answer. No, no, no. A is not the answer. No. Prevertebral fascia. Someone answered prevertebral fascia. Yes, that is the correct answer. Prevertebral fascia, axillary sheath is derived from prevertebral fascia. Okay, so that is again very correct answer. Okay, all right, then we can begin with the lower limb. Are you ready, guys? So we are almost on time. Just 7 minutes have passed 10, so we have completed most of the important areas. Definitely have many areas are still left. I would not say whole of the upper limb has been discussed, but yes, we have touched upon many important areas of upper limb. So everyone ready for lower limb? Please give me a thumbs up so that we can begin with the lower limb discussion. Yes. Okay, great. So let us begin. Disturbing a lot. Please refresh if it is causing issue and select the settings. Go to the settings and select auto. Okay, or you can select auto is the best thing to do. Okay, so that you can join comfortably. Okay, and download the Android application. Next time it will be much easy, but I will try to do it on YouTube. That don't worry on that. I will see for the next time. Just bear with me for the first session. Okay, all right. So now, yeah, some the last question, last regarding the auxiliary sheath. For this, let me, it will take a little bit time, that's why I have to go on to the boundaries and so here, which is the sheath is the one which is being derived from the prevertebral fascia. We have already discussed this point. Axillary sheath is being derived from the prevertebral. So you can go for the regular theory classes of mine where I have discussed everything. It's definitely not the clavipectoral fascia. We have discussed that clavipectoral fascia is the one which is present sandwiched below the pectoralis major and above the pectoralis minor. It is enclosing two major muscles, subclavius and the pectoralis minor. Okay, so and the four structures passing through the clavipectoral fascia. Okay, and pectoral fascia is on top of the pectoralis major, so you can use the rule of exception also in that case. For now, then we talk about the lower limb. Now first question in the lower limb, try to answer this one. Okay, try to answer this question. The patient presents with the pelvic drop on the right side during walking. The left hip abductors are weak. Okay, so which nerve or muscle group is affected? Just hold on, give me, before I begin with this lower limb discussion, just I want a 2 minutes break. Just give me 2 minutes break. You can also wander. Okay, 2 minutes break. Just stay connected. Okay, I will be back in 2 minutes. hope everything is fine. Audio. So we continue the discussion for the lower limb now. Yeah, don't worry, I will see for the next class. Okay? Don't worry on that. Okay, just bear with me for the first day. I will share the recording of today also. So maybe on the Sunday tomorrow you can see in the morning hours. Okay, don't worry. You will not be at any loss in the academic way. Don't worry on that. Okay, trust me on that. So can we begin? Everyone is back? Yes. All right. So the patient was having a pelvic drop on the right side during walking and left hip abductors are weak. Which nerve or group is affected? So they are actually asking you about some test. Do you know the name of the test which is related to this this language of the question? Anyone? The correct answer for this question? Recording available रहेगा, don't worry. I am telling you since the beginning. Do not panic. जो भी मैं classes दे रहा हूँ मैं record करूँगा. I will be there for you, all of you. Don't worry on that. Please relax on that thing. Okay. But please try to answer if you are there right now. Trendelenburg. TB नहीं लिखना, Trendelenburg. Right. Okay. So they are asking which muscle is related to this test. So you mostly they tend to confuse you between the maximus and medius. Okay. So anyone remembers what is the correct answer for maximus or medius? Anyone for this? Which is the muscle which they are asking about? The correct answer is okay. Yes, mostly people are answering it right. So the correct answer is B. That is the gluteus medius. So have a look at this in the lower limb section. Okay, in the gluteal region if we go about. Okay, I'm just going in the gluteal region where we have already discussed all these things: nether lines, the Bryant's triangle, the nerve supply, okay, the sciatic foramens, and then the muscle. This is the gluteus maximus muscle. Okay, we have seen in 3D rotations also the origin and insertion. Recently it was asked for the gluteus maximus origin and insertion was recently asked in the INI-CET November exam. Okay, so that I have already covered in the INI-CET November discussion exam discussion questions, and you can see the gluteus maximus muscle here, which is having an extensive origin and the insertion on the iliotibial tract. Then there was the muscle that is the gluteus medius, and then deep to it the gluteus minimus. Okay, so if you cut this one, it is the gluteus medius. Here you know the gluteus maximus has been cut. Here the gluteus medius is visible. Then medius has been cut and the minimus is visible right now. Okay. So now you see this image also. This is also important. It was recently asked again. So you know the sequence of these muscles: the gluteus minimus, then you have the gluteus, the piriformis, the key muscle of the gluteal region. Then you have the superior gemellus, tendon of the obturator internus, not externus, internus, and then inferior gemellus, and then pronator quadratus. Okay, so these muscles in sequence are very important for identification purposes. And then you come on to this one, that is a Trendelenburg sign. Okay, so have a look at this. Let me show you them side by side. Okay, so have a look at this one. This is showing you the normal case scenario where the normal gluteus medius and minimus are functioning. See, please remember Trendelenburg, the pelvic drop or everything is related to which muscle? That is a gluteus medius and minimus. We are not talking about the maximus here. Okay, so paralyzed gluteus medius and minimus, that is causing the sagging of the pelvis on the unsupported side. Okay, on this side. So you can see the paralysis is happening on one side and the pelvic drop is happening on the unsupported side. You can see the same in this photograph, Trendelenburg sign. So pull, this is a normal case scenario where is a pull by the gluteus medius and minimus where the other foot is off the ground. Foot off the ground is very important. Okay, that is the opposite side. So it prevents the sagging of pelvis on the unsupported side. That is a normal case scenario. Suppose if this muscle is paralyzed, so what is happening? There will be sagging of pelvis or pelvic drop on the opposite side. By what thing? By the weight of the limb. Okay, that is also important to be understand. And foot is off the ground in the on the opposite side, obviously. Then we are discussing. Okay, so that way you can remember. So the answer is very clear. That is the gluteus medius, and you know it is supplied by the superior gluteal nerve. Inferior gluteal nerve on the other hand is supplying the gluteus maximus. That is also something contrasting to remember. Next question, try to answer this one. Anyone try to answer this question? Next one. And I recommend all of you to please attend these classes live. Don't wait for the recordings to be available and then you will sit down, you will नारियल फोड़ोगे और फिर वो recordings को देखने बैठोगे. Already you have plethora of resources. Recordings बहुत सारी हैं, सारे subjects की हैं. So recordings देखने बैठोगे वो दिन कभी नहीं आता, ठीक है. So please attend maximum classes live जहाँ पे भी you can attend so that you learn better. Okay. Otherwise कोई फ़ायदा नहीं है classes का. So lower limb case number 2. 25-year-old footballer XYZ story. The question is asked about the unhappy triad of Donog. Okay, unhappy triad of Donog. Yes, the correct answer, most of the people have answered correctly. The correct answer is the D answer, that is the DLCL, that is the lateral collateral ligament. Okay, so unhappy triad of Donog does not have D as the component. Okay, so let me go to that part. I hope you remember this, we have already discussed. We go on to the lower limb, okay, and we go on to this knee joint. Okay, here we have already discussed all this. Knee joint is very important. Okay, there is a lot of MCQs which are frequently asked from the knee joint, so I will be just briefly touching upon those MCQs so that we can skip the later parts very easily. So the knee joint classification, it comes under the category of modified hinge variety. Okay, synovial joint but modified hinge joint. And this images we have already discussed. This is the popliteus muscle, the deepest muscle in this knee joint. Okay, all these ligaments you are aware. Then this image very well. This is very famous image. Okay, this is regarding the Medical College Lucknow Medical College mnemonic for the posterior cruciate ligament. Okay, the medial meniscus, lateral meniscus, posterior horn and then anterior horn, anterior cruciate ligament, medial meniscus. So the mnemonic we have already discussed in detail in the classes. So that is from anterior to posterior. The mnemonic is from anterior to posterior in this manner. Okay, sequence is this. Then we have also discussed regarding the cruciate ligaments. So remember, cruciate ligaments are intracapsular but extrasynovial. That has also been asked in the exams. Then anterior cruciate and posterior cruciate. So you just remember one, other one will be easy. So anterior cruciate ligament is from the posterior part of lateral condyle of the femur to the anterior part of intercondylar area of tibia. Even if you don't remember the extension, that is okay. Just remember a very important area from these ligaments, that anterior cruciate ligament is the one which is taut in the knee extension. So when you are standing, knee is extended, this is the ACL which is tighten up, okay, comparatively to the PCL which is taut in the knee flexion. So when you are sitting relaxed, so PCL is in tight position. Then we discussed regarding the draw test, that has also been covered in the orthopedics also. But here there is a very important thing regarding the slipping or sliding of the bones. So please remember this one paragraph and you can remember the other one for the PCL. So ACL, same color. ACL, it prevents the femur from sliding posteriorly on tibia. You may or may not remember this statement. Just remember this one. It prevents the tibia from sliding anteriorly onto the femur. So please imagine on your own body and you can remember. Okay, it prevents the tibia from sliding anteriorly onto the femur. So that is the ACL, and PCL exactly opposite. So from this also MCQs are asked, and other things the draw signs. So ACL the draw sign, anterior draw sign, posterior draw sign for the ruptured. PCL, that is not a difficult thing. Then there are some bursas in the knee joint, okay, related to the knee joint. What are the names? This is the quadriceps tendon which is having this bone here, that is the patella, okay. You can see this. Then you have the ligamentum patellae which is attached distally, okay. So there is bursa which is present, that is just anterior to it there will be a pre-patellar bursa. Then there will be above the patella suprapatellar, below the patella there are infrapatellar bursas, this one, but there is a deep one and there is a subcutaneous superficial one or subcutaneous one, okay. So subcutaneous infrapatellar bursa and deep infrapatellar bursa, simple. Okay, then you have the answer in bursa, no one is going to ask you. Then popliteal bursa, again no one is going to ask you. But please remember these bursas, these 4 bursas are very important, which are frequently asked in the exams. Okay, and then this pes anserinus, if you remember the head and neck region, pes anserinus. Okay, the pes anserinus 5 branching pattern we will discuss in head and neck. But here there is these 3 muscles, the semitendinosus, gracilis and sartorius in the knee joint attachment. Here you have the pes anserinus which is formed. Okay, pes anserinus. Then we come on to the very important entities. I am revising the knee joint important areas in one go because many MCQs are framed for the knee joint as well, so it will save us time. Okay, we are covering everything importantly. So now you see this is the housemaid or housemaid's knee which we are referring to. Direct questions from the exam, they are asked regarding the housemaid's knee. Okay, so what is that housemaid's knee? It is regarding the prepatellar bursitis. So the one bursa which is in front of the patella or anterior to the patella, it is getting inflamed. Why so? Because just imagine if a maid is doing this cleaning the mopping the floor, and her knees are rubbing against the floor continuously due to the friction, repeated friction, there can be prepatellar bursitis. This also happens in the case of carpenter function, so carpenter's knee. So classically housemaid's knee is asked. Okay, then you come on to this clergyman's knee. Have a look at this clergyman's knee. Let me just bring it here. Yeah, clergyman's knee is, see, clergyman, the one who is doing a prayer in the church. Okay, so when he is sitting in this manner continuously for a very long time, then you have a infrapatellar bursitis. Now you remember there was a deep infrapatellar bursa and a subcutaneous one. Classically in the clergyman's knee there is a involvement of subcutaneous infrapatellar bursitis. There is not deep one, I am talking about the subcutaneous one. That is the main catch point. Then you have the Baker's cyst, which is the popliteal cyst, inflammation of bursa lying deep to the semimembranosus. So that has also been asked in the AIIMS INI-CET exams. Then we come on to these flexion and extensions. Okay, this we have already covered, I am not going to detail for this one. Just have a look at the locking and unlocking. That is very important topic of the knee joint. Knee joint is incomplete if we don't discuss this locking and unlocking. So first, locking position of the knee joint. Where is this locking position? It is in the last phase of extension. Extension is, imagine on your body when you are standing in the last phase of extension, there is locking of the knee joint. Compare this with the unlocking of knee joint in the beginning of the flexion. That is very important. Okay, then if you compare this movement with respect to the movement with foot on the ground, that is again important. Medial rotation of femur, lateral rotation of femur, maybe you can skip, you do not remember, that is okay. So let me mark the most important areas in this flow chart which you have to, also in this table. One is the occurrence, that is in the last phase of extension, that is in the beginning of the flexion. That is most important area to ask for the locking unlocking. Okay, then what else? The muscle responsible for these things, the locking and unlocking, that is vastus medialis and popliteus. Very important. Okay, so vastus medialis is the muscle which is responsible for the locking of knee joint, whereas popliteus, classically very important muscle is popliteus, which is asked frequently, that is for the unlocking. So you can remember in the beginning of the flexion, so when you are able to relax the body, when you are sitting in the beginning of the flexion, there is action of the popliteus. So it's a position that is relaxed position. Please remember ligaments are relaxed in the unlocking. Compared to this, ligaments are very tight in the locking position. So when you are standing, okay, yeah, that is true. So when you are standing, so ligaments are tight, as I told you previously, same thing. Okay, so joint can be flexed in the unlocking, joint becomes rigid in the locking. So these are very important areas for locking and unlocking. Many questions, many along the years they are being asked. Then I show you this one, the classical MCQ which was asked, through which we have reached this knee joint actually. This is the involvement of the terrible triad. Terrible triad, also known as unhappy triad of Donoghue. Okay, Donoghue, D-O-N-O-G-H-U-E. Okay, so that is unhappy triad of Donoghue, where you have the involvement of what all structures? The anterior cruciate ligament, the medial collateral ligament and medial meniscus. Okay, so the option which was given to us in the MCQ was LCL, that is the lateral collateral ligament. That is not the correct answer. Okay, even the PCL, that is the posterior cruciate ligament, is also not the answer. So they can confuse you with these words. Okay, so ACL plus medial collateral ligament plus medial meniscus, these are the ones which are important for the unhappy triad of Donogh. Okay, so that covers our most important topic of the lower limb, that is the knee joint most important areas. So I hope you can solve this MCQ. We have discussed this already. Anyone would like to answer for this? We have a lot of participants. Please try to answer this question. The people who will attend live, I am damn sure they will be able to do wonders in the exam, because they will be able to recall. Otherwise, recording is a recording only. You know, you have a lot of recordings. So try to answer this question. The question is regarding the inflammation of prepatellar bursa. Okay, prepatellar, very classical question, prepatellar bursa. So what is the correct answer? Yes, most of you have answered correctly. I am happy. The answer is housemaid's knee. Yes, excellent answer. That is the housemaid's knee. And now you know the basics also. You're not just mugging the answer, you know the basics also, right? Okay, next question. Again related to the knee joint. So these are all your previous year questions only. I am not making any new questions. Everything is from the previous year data, recall based MCQs. So patient is unable to initiate the knee flexion, after full extension. Do it on your body and just remember that way. Okay, so what they are asking, initiate the knee flexion after full extension. Matlab, when you are trying to sit from the standing position, you are not able to do that comfortably. So internal rotation of the tibia is being lost. Yes, so what thing we are talking about? We are talking about which muscle? That is, yes, very easy question, again very easy question. That is, the answer is popliteus. Yes, many people have answered correctly. I am happy you have understood this topic. So once you apply this knowledge in the MCQs, you will be able to solve better. And don't worry, I will be soon be releasing some MCQ pattern in your entrance exam or in your main theory exams, how you get the MCQs. I will be releasing some MCQ quizzes in this, again same platform only. So at your ease, you can use your desktop or any computer or mobile Android application, and you can have a real feel of the NEET-PG entrance exam, because this platform gives you that edge to do the same mark for review and all those pattern questions. You can solve them in this way. I will be adding those things eventually very soon. I have already added for general anatomy section for some students, so you can have a look how it functions. Okay, if it feels good, you can message me. I will add any number of quizzes for full anatomy revision, for upper limb revision, for lower limb revision. I will do everything. iOS का ऐप थोड़ा महंगा है. It will be out, don't worry. First let me just start up with this. It's a primarily, I am the CEO, I have just started up, so please bear with me. It's a new thing. I am a very tech savvy person. I am totally amused what happened today, why people are not able to connect, and I am damn sure there is some internet connection problem for your end, or maybe some server issue from the back end, because sometimes people are taking the classes simultaneously. Don't worry, we will sort everything together. Okay, I am not running anywhere. I am available everywhere with anyone discussion. Next question, again easy question. Try to answer. Yes, try to answer this question. Donald Trump. Okay, big fan sir. Okay, thank you, but I don't know who are you. Okay, so anyways, try to answer this question. A runner presents with swelling behind the knee, cyst deep to the semimembranosus is diagnosed. So what they are asking about, actually this question is very easy and very simple. Some questions I have given simple also, so that you gain more confidence, but I am happy difficult questions also you are able to solve. Okay, the correct answer is very simple, that is the semimembranous bursa. But can anyone tell me what is the name of the cyst? Anyone can tell me the name of the cyst which they are talking about? The answer is B, definitely. What is the cyst, name of the cyst? Anyone? Baker's cyst. Yeah, very good. We have already covered recently, so that was the question. Next, Again, difficult question or easy question? Let's see your response on this question. This is regarding the knee joint again. If you find, trust me, the gluteal region and the knee joint are the primary areas where the NEET-PG INI questions are framed from the lower limb. Okay, very frequently questions are asked from these two regions, the favorite regions, so gluteal and the knee joint. The trauma patient possibility of the tibia to remain stable, the main line which you have to remember. The sides posteriorly. So which ligament is being done? We have already covered this. Recap. If you have answered correctly, yes, the correct answer is A. That's the ACL. ACL is anterior already. Okay, great. Then next question. This is quite easy. Now direct one-liner MCQs, because those have also been asked. These same questions are asked from the previous year questions again. Yes, anyone for this question? Great saphenous vein. Sometimes way years back, 2 years back, the same question was asked in the form of an image based question. Okay, so you have to remember that way. So the question is regarding the great saphenous vein. It runs where? Okay, the answer is, I'm getting a mixed response for this question. The answer is yes, the answer is B, that is anterior to medial malleolus. So I need to remember this. Let us go for the venous drainage of lower limb. Okay, venous drainage of lower limb. Let us see this. Okay, so we have already discussed the perforators in this topic. Okay, perforators, the Hunterian perforator, the Boyd's perforator, Cockett's perforator. Okay, then we have discussed regarding this superficial epigastric vessels, superficial external pudendal, superficial circumflex iliac. Okay, then if we talk about this femoral region, the saphenous vein, now have a look at this image to clear yourself. Please don't be typing anything extra in the chat. Just answer the main question only which is asked. Okay, so now you see this is the image for the long saphenous or the great saphenous vein, and then you have the short saphenous vein, okay, or the small saphenous vein. Now you see there is a difference between the formation and position of these saphenous veins. So let me show you this this table to make things very crystal clear in your mind. Great saphenous vein. Okay, so the important areas which are asked, it runs anterior to the medial malleus. Imagine on your body, okay, any foot you imagine where the great saphenous is running, where the short saphenous is running, you will always remember for your entire life. So great saphenous is running anterior to the medial malleolus. Okay, then short saphenous is running posterior to the lateral malleus. We have already seen everything in 3D in the lower limb classes. I am just now briefing things up so that we can complete majority of the topics in small time. Okay, so contrast, short saphenous, it is running posterior to the lateral malleolus. Now I give you a very great analogy for this. Do you remember the same story in the upper limb? We discussed regarding a nerve. Okay, the medial epicondyle, behind the medial epicondyle we had a nerve, that was the ulnar nerve. In front of the lateral epicondyle we had a nerve, that was the radial nerve. Similarly, that was important concept in upper limb. Important concept in lower limb regarding the malleoli. So anterior to the medial malleolus is great saphenous vein. Posterior to the lateral malleolus is the short saphenous vein. So that is important. Another important question which has been asked in INI-CET also, in NEET also, that is regarding the saphenous nerve and sural nerve. Okay, so related sensory nerve to the great saphenous vein. So great saphenous vein and a nerve, they both are running in close approximation. So that is saphenous nerve. So if you are taking a section, that is a venous section of the great saphenous vein, which is commonly performed, so you can accidentally damage the saphenous nerve. So you have to be very careful regarding the same. Similar conditions, short saphenous is related to the sural. So remember one, you will remember the other one. Okay. Then great saphenous opens into the femoral vein and short saphenous opens into the popliteal vein. Okay, so that is already clear. Okay, then we have varicose also, All right, next we come on to the next topic, that is the arches. So do you know the answer to this question? Try to answer this, maybe you are able to. Please give a try. Okay, people are answering C. Okay, just think once, just think carefully and answer. Head of talus. Yes, now the answer has come, that is the answer is head of talus. So let us see the arches now. You should be understanding regarding the keystone. Okay, so keystone concept. Let us come to the arches for a while. Arches have always been important since many time. Okay, coming to the arches now. Okay, so now very easy concept for arches, but before we dive into the arches, I want you to see this photograph. What is this photograph about? This is showing you, just imagine a suspension bridge. Okay, like you have seen in movies, a suspension bridge where you have this arch like thing. You can see this arch like thing, okay, which is holding, this is the bridge. Okay, and there are some cables, suspension cables, if you know, if you have seen in the movies, right? So now you see what is happening. Suppose if there is the bones which are holded in this manner, these are the bones, wedge shaped stones, stone bridge. Basically we're talking about the stone bridge. Okay, so this is a stone bridge. So if the stones are representing the bones, okay, so that is the same case scenario in the foot. So these are the small bones which are there, and then you have a center bone. Okay, that is the keystone in the centerpiece, that is the keystone, and you have a sling which is holding the keystone from the top in the center. Okay, then you have the tie beams which are holding the base, the pillars, basically the main pillars, the lower most bones of the pillars. These are being held by the tie beams, connected by the tie beams, just like a bow. Okay, like an arrow, even you have an arrow and a bow, so same kind of condition. And then between the small bones, or in this case stones, we have some ties. So these are the intersegmental ties. Okay, so these are the main words which we'll be using, that is a sling which is holding from the center, pulling it up, keystone, centerpiece, then you have the wedge shaped bones here in this case scenario, then you have the tie beam in the bottom which is maintaining the arch. Actually, suppose if this tie beam is cut, so the arch will collapse. Okay, then you have the intersegmental ties. So let us place the same information in the foot. Okay, so have a look at this image, very crystal clear image to understand. So you know the bones of the foot. So this big bone, this is the calcaneum. You can see the top bone, that is a talus. Okay, calcaneum, or the heel bone, if you remember, when you are standing, that is a heel bone. Above it, that is a talus. Then you have the navicular, that is appearing to be like a ship. Okay, nauka. Okay, that is navicular. Then boat like, basically. Then you have just immediately, you know, inside of this, on the sides of this, that is the medial side of the navicular, you have the cuboid bone. Okay, then you have, lateral side, I'm so sorry, lateral side. And then you have the cuneiforms, the three cuneiforms. Okay, in which you have the intermediate cuneiform. Okay, and then you have the medial cuneiform, lateral cuneiform. Okay, so all these cuneiforms, this one, all these three cuneiforms. And then you have the metatarsals, not the metacarpal, the metatarsals. Okay, so here, and then you have the phalanges. Okay, so you know the names of the bones. So now see, just divide this foot into one side. So now see, medial bones are forming the medial longitudinal arch. Okay, so in this talus, the head of the talus primarily, that is a keystone. Calcaneum, specifically the medial part, is the part of medial longitudinal arch, along with navicular and the three cuneiforms and the medial three tarsal bones, metatarsal bones. Okay, where you have the calcaneum lateral part, the cuboid bone, and the lateral two metatarsals. So less number of bones in the lateral longitudinal arch, and it is less important. Okay, so more important medial longitudinal arch. Remember that way, you will never forget. Okay, so let us have a look. In this case scenario, if I just show you this photograph, now you see, have a look. Okay, this gives you the hint to answer everything. Okay, so you can see how the arch is being formed. Now we are looking at the medial longitudinal arch specifically. Now you see what we are looking at. So this image we are looking at this part, okay. On the medial side we are looking out from the lateral view of the medial longitudinal arch basically, okay. So now see all the MCQs available here. Talus is resembling the keystone, the highest bone in the stone bridge, you remember. Then the summit is the top part, again superior articular surface of the body of talus, we have seen that already. Then you have the main joint, which is also asked in the MCQs, that is the TCN, talocalcaneonavicular joint. Do you remember, any one of you, if you can recall, what is the type of joint, this talocalcaneonavicular joint? What is this, in what type of joint category it falls? Excellent answer, ball and socket joint. So total in the whole entire body we have 4 ball and socket joints. Out of this, talocalcaneonavicular is 1, okay. Then you have the metatarsal, the first metatarsal, which we are looking at from the lateral view, okay. So you can see here you have the medial cuneiform, the navicular, okay, all these bones same which we discussed, but the important MCQ answered, that is a talus is the keystone, okay. Then you look at this lateral longitudinal arch from the lateral view. Now you see in this lateral longitudinal arch, what is the main point? We have less number of bones, are easy peasy. So top bone, it seems to be in the same line, but it is in the center and the top, that is the cuboid, okay. Yes, that is okay. So cuboid, that is a keystone, and here you have the main joint in the center. See, main joint means if this joint is not there or any problem in this joint, then the arch will be collapsing, simple, okay. So you have this calcaneocuboid joint, okay, calcaneocuboid joint. This joint is the one which is the main joint, okay. Then you have the summit. Now summit is the articular facets in the superior surface of the calcaneum. So this is the summit, okay, the highest point in the arch, basically, simple, okay. So that is the articular facets on the superior surface of the calcaneum. That is for the lateral longitudinal arch. Now please pay attention, very important point I am going to tell you. Can you see these 3 images now all together? Please pay attention, the main point which they keep on asking and you get confused. Pay attention to the talus bone. Talus bone seems to be the highest bone, yes or no? Yes. So you can see it is the part of medial longitudinal arch, it is not the part of lateral longitudinal arch, and that is the reason if they ask you keystone or if they ask you summit, they will primarily ask you in the medial longitudinal arch. That's where they need you to tell the talus. You know, you will get confused कि talus तो ऊपर होती है, maybe it is in the lateral one also. It's not, it's only the medial longitudinal arch. So that's the main point to remember. And the main joint also is important, TCN, one of the ball and socket joint which I told you. So again, these are important areas you cannot afford to skip. Then you have these tables for the comparison, we have already discussed in the classes in detail. I'm not going to detail right away. Then you have the same intersegmented. So all these names you can see the anterior end, okay, you can see now carefully, okay. So this is quality, utility, then shape, anterior end, posterior end, the summit we have discussed, anterior pillar, posterior pillar, the key joint, keystone, okay. Then you have the intersegmental ties, the tie beams, the slings, all these things we have discussed in detail in the classes. So please pay attention and revise that. Don't miss this part of the medial longitudinal arch, and if you don't want to read anything, just remember what I have told you out of this topic, okay. Then you also have transverse arches, which are less frequently asked in the exams, but yes, in the theory exams that can be asked, anterior and posterior transverse arches, so please remember. And then you have these orthopedic conditions, if you remember, the talipus, equinus, calcaneus, varus, valgus and equinovarus. So CTEV, that was the CTEV, congenital talipus equinovarus, okay. So that also we have discussed, okay. So now you know the keystone of medial longitudinal arch. Next question, try to answer this question. We are almost towards the end of this session. We will be definitely be completing in the next 5 minutes, so don't worry. Chief extensor of the hip joint is asked. Please try to answer this. Try to answer this question. Okay. Chief extensor of the hip joint. The correct answer would be the, most of the people are answering as A. Yes, the correct answer is gluteus maximus. Gluteus maximus. Let us have a look at this hip joint topic. In this, if we go for the hip joint, okay, so hip joint we have already discussed, if you remember, about all these ligaments: the pubofemoral ligament, the iliofemoral ligament, the strongest ligament, right? So then we come on to this table, if you know. Okay, this is a table which was discussed in the topic of hip joint. Okay, so flexion again by the psoas major and iliacus. Gluteus maximus and hamstring muscles are responsible for the extension, whereas gluteus maximus is a chief extensor. Okay, what about the adductors? Adductor longus, brevis, magnus, adductor compartment, you are aware. Abduction by the gluteus medius and minimus. Very important to remember. This abduction is important, extension is important to remember. See, don't worry about these muscles. Please remember where they are present in the body. You know where is gluteus maximus. So when it will contract, it will cause extension of the lower limb. The limb will go back. Just imagine where they are, and when they will contract, what bones they will approximate to each other. That's the best way to remember all the muscles in the entire human body. Okay. Then medial rotation. Medial rotation, that is by the gluteus medius and minimus, again also by the tensor fasciae lata. We have already discussed that also. Lateral rotation by the obturator internus with these two gemelli, quadratus femoris. You remember we have discussed this also previously regarding the sequence of the muscles in the gluteal region under cover of the gluteus maximus. Then circumduction will be the combination movement only. Okay, so that was about this question. Then this is the last question. Try to answer this one. Maybe you are able to. Try to do it. We have already discussed. Yes, answer is B. Yes, that is correct. That is calcaneocuboid. We just now discussed. I told you, although it's less frequently asked, but yes, sometimes it is also asked. Okay, calcaneocuboid. So that is it about this session, where we have discussed regarding the lower limb and upper limb few important topics. And just before closing this session, I would like to tell you that this upper limb, so just have a look at this index. Okay, here in the upper limb, these are all the topics. See, I have deliberately left some of the less important topics, okay, in this classes, but please pay attention to these must know topics. This will help you to solve through any exam, be it MBBS first year solving theory exams, or you are solving your entrance level exam, NEET, INI, everything has been covered. So you can blindly trust this resource and follow through. Trust me on this. I am telling you with years of practice and assimilation of these notes. So axillary artery, brachial artery, please remember the origin, branches and termination. Clavipectoral fascia, structures piercing through the clavipectoral fascia. Intermuscular spaces, revise through the space, that is the quadrangular space, upper triangular, lower triangular space. Axilla, boundaries and contents are the most important thing. Then cubital fossa, again boundaries and contents. Then you have flexor retinaculum, structures passing superficial to it, deep to it, the diagram that is important. Extensor retinaculum, we have 6 compartments if you remember. The anatomical snuff box, the boundaries where the roof is important, cephalic vein, contents, radial artery, and the bone which is present in the floor, that is a scaphoid. Okay, I am talking about the nutshell upper limb. Then you have muscles of the hand, the interossei, lumbricals, the thenar group, hypothenar group. Revise what we have discussed. Okay, so that is all the important muscles names. You don't need to bother about the origin insertion, just follow through the muscles names and the nerve supply, and action preferably is not difficult because flexor pollicis will flex, that is very easy. Okay, then radial nerve, median nerve, ulnar nerve, please remember the origin point, the terminal branches in the pathway wherever it is supplying all the branches, to which muscles are supplied. and also the exceptions like the FDP, medial half, lateral half, all these are important. Then you know there are some signs which are very important, which is, that is, if you remember the recent INI-CET MCQ exam, November exam, there was an MCQ based on the injury to the median nerve. That was the weak OK sign. Okay, so weak OK, right, weak OK sign, that was because of the injury to the median nerve, that is specifically the anterior interosseous nerve, where the deep flexors of the forearm were affected. So you know there will be weakness of the flexion of the thumb and the index finger. So that was the weak OK sign, classical presence for the median nerve injuries. We have already discussed that also. Then ulnar nerve injury, ulnar claw hand, you know, ulnar paradox important, radial nerve injury, crutch paralysis, Saturday night palsy, classical questions. Okay, you cannot skip them. Then shoulder joint injuries, again surgical neck of humerus, shoulder dislocation, important in orthopedics as well. Elbow joint related to all the injuries related to the elbow joint, again clinically very relevant. Then we come on to the nutshell of the lower limb. Okay, so these topics we have already discussed. Okay, so I'm just giving you a brief where you have to touch upon in the revision classes. Front of thigh, the fascia and the muscles. So the muscles which are forming the boundaries of the femoral triangle, the contents of femoral triangle, the nerves and vessels, very important. Okay, what else? The contrasting difference between the carotid sheath contents and the femoral sheath contents. Femoral sheath does not have the femoral nerve inside it, whereas the carotid sheath has the nerve, that is the vagus nerve inside it. So that is contrasting between upper limb, lower limb. So please remember these things. Then medial side of thigh, adductor canal. So in the beginning of upper limb, lower limb, we have already discussed all the muscles of each limb in detail in 3D as well as in 2D. So please remember the muscles names at least, that is the first job. Second job is to know the nerves of the compartment. So suppose if you remember the front of the arm, there was the musculocutaneous nerve, which was the nerve of that compartment. And similarly, you have nerves compartments in the lower limb also. So remember the medial side of thigh, its compartment nerve, obturator nerve. Posteriorly we have sciatic nerve. Anteriorly we have femoral nerve. Okay. Then venous drainage of lower limb. Classically I told you great saphenous, short saphenous nerve, vein. Okay. Then gluteal region. We have discussed gluteus maximus, medius minimus, Trendelenburg sign. Very important things. Okay. Then we have the posterior compartment of the thigh, where we have again the muscles in the posterior compartment of the region, which are supplied by again sciatic nerve. So you have to remember the sciatic nerve, obturator nerve, femoral nerve, its branches, very important. Its divisions are also important. Hip joint, we have discussed in nutshell the extensors and flexors, abductors, adductors at the hip joint. So muscles in this joint are very important apart from the ligaments, that is the iliofemoral, pubofemoral. Then you have popliteal fossa. Again, fossa is there, so we have boundaries and contents. Okay, very simple topic. Front of leg and dorsum of foot. Again, same thing. We have to discuss all the compartments, its nerves, and the muscles name. Okay. Then you have the lateral and the medial side of leg. Same thing. We have to remember the difference between the forearm. In the forearm, we have only two compartments, the flexor and the extensor. Whereas in the leg region, we have three. So you have to differentiate and remember where you have the lateral side, medial side, okay, front of leg. So you have to remember these compartment systems. Then knee joint we have discussed already in quite detail. We have revised it. Okay. Then back of the leg also again important for the regions. Again, here a very important point comes, that is the retinaculums. So structures passing deep to the flexor retinaculum, extensor retinaculum, and that is different in position with respect to the upper limb and lower limb. It's exactly opposite. So please remember the structures passing deep to the retinaculums. There is also another retinaculum, peroneal. So please remember that also. Then we have the sole of the foot. You know the layers of the sole of the foot. So the main chunk of that topic is to remember the muscles and the tendons in each of the layers and what is the dominant nerve of the foot. You know the dominant nerve of the hand, that is the ulnar nerve. In the foot, we have the lateral plantar nerve, that is the dominant nerve of the foot. We have already discussed that in the classes. What is the concept of dominant nerve? That means that nerve is supplying the muscles in sequence from superficial to deep in majority. Okay, so deeper muscles classically supplied in that region primarily by that nerve. Okay, so all the interossei, adductors, these are all supplied by the dominant nerve of that area. Then arches of the foot, the medial longitudinal arch, lateral longitudinal arch, transverse arches, all these along with the clinical integration, the pes planus, the equinovarus, CTEV, all these are important not only from anatomy, also from orthopedics aspect. So that is a nutshell of upper limb, lower limb, and things we have not been discussed, and it's actually practically not possible to discuss the entire anatomy in 2 hours. But yes, through these discussions, I will touch upon the major important areas. So please feel free to follow up. You can follow my Instagram handle, my YouTube channel, and also you can download this app Inside Our Body, which I have created myself only. No third person is involved, so you can feel free to join it. I will posting many free content, and keep on joining in large numbers and utilize this platform, which is my dream to create a platform for the benefit of the mankind. Okay, so I hope you liked today's discussion. Thank you so much, and I really hope next class will be sorted up. So I think last part of the class was quite smooth. No one have any problem in the last part, right? So anyways, I'll be sharing the recording if the people who have missed, so revise the entire anatomy. So see you soon next time. Thank you so much.